So we're very excited to be here. Welcome. And this is Med Talks. We're excited to be back again this year. And we have a very important topic, with the government reopening and the Big Beautiful Bill Act that passed in July. It's an important time for us to get together and learn about what's happening in the landscape with behavioral health. So our keynote today with Kelly Causey, she is with the Behavioral Health Administration. And I just want to go over a few logistics before I get into the exciting part of what she's up to and what she's going to share in her keynote. So there are bathrooms. If you go all the way back past the elevators, they're on the right. And if you didn't see when you came in, there is coffee, water, refreshments, and food in this front room right here on the right. Hopefully you all got something good to eat. Feel free to grab something. We are going to have a break after the keynote, so thank you for the agenda. Here. Break will be at 9:30 for 15 minutes. And then we have an exciting panel today, a panel discussion with 4 different groups that are here from Denver Health, Aurora Mental Health and Recovery, Vail Health, and Children's Hospital, Colorado. So we're very excited to hear from them this morning and really unpack what Kelly's going to kick us off with. So 4 of the key topics that we're going to discuss this morning are really around what's happening in the community in Colorado. So Behavioral Health Administration and what they're doing. We're going to look at exactly what those goals are for the year. Kelly's going to lay those out for the group. And with those objectives, there's an advancing of behavioral health equity and integrated care. So she'll kind of unpack that some more. The federal policy impacts that we're seeing with BBB, or HR1, whatever you call it, Medicaid cuts, work requirements, and SNAP benefits that have been reduced, and the ripple effects on Colorado in particular for all of our behavioral health systems. So, and lastly, but most importantly, is where are we going? What are the strategic considerations, and how do we continue to have these conversations in our communities, whether we're designers? So raise of hands, who's a owner here or owner's rep? Okay, and do we have design engineers in the room? Architects? Yeah, great, awesome. So we have a good mix, kind of both sides, right? So with that said, we're going to kick it off with Kelly. Is there any questions before we get going? And you can reach out to Mike, Trevor. Can you raise your hands? Those of us that coordinated the event. I don't know where Mike is. If you have a question or need something, feel free to come talk to Mike or Trevor or I. All right, so Kelly Causey. Let's give her a little round of applause. So Kelly Causey is Colorado Behavioral Health Administration's Deputy Commissioner, and she joined BHA after 7 years as President and CEO of the Colorado Children's Campaign, where she advocated for for Colorado's children and was responsible for the strategic leadership and advancement of the organization's mission. Before that, she served for 18 years as CEO of Mile High Youth Corps, which employed, educated, and trained young adults who served on community-based projects and delivered services for 15 counties. Kelly holds a PhD in health and behavioral sciences from the University of Colorado, Denver, and a BA in psychology from Scripps College. She's been in Colorado for almost 30 years, and in her free time, she can be found at a CU game or at the theater. We're so excited you're here.
Thank you. Thank you. Good morning, everybody. I like it. This is our brain candy. I was saying, instead of just getting online right away or being in meetings and in the grind and all that, we get a chance to just be in community this morning and share ideas and have a good conversation. And I'm really honored to be here with you all and to kick off what I think will be a more interesting, exciting panel discussion that'll follow after this. So again, I also am thrilled Trevor is on the board of Mile High Youth Corps, and it's how I knew some of you in your construction companies and worked with Saunders and Turner and PCL and others. And so I was really happy to be able to be Commissioner Smith's stunt double today and be with you all. So I'm gonna cover some ground today and share with you BHA. How many of you know of the Behavioral Health Administration? It's okay if you don't, but okay. That helps me. So I'm going to share a bit about BHA and the goals and all that, as Rebecca said, but also then dive in more deeply to the impacts on the federal swirl, as I call it. And thank goodness the shutdown is now over, for at least for now. And so I'm going to share some of that and also where we're headed and some of the things that are ahead for BHA, and leave time, of course, for Q&A. So if there's something top of mind for you or a spark that you had or something you just feel like BHA should know, I'm here for that too. So looking forward to the conversation. I want us to take a minute. When I pick this sort of imagery, I know some of you are also in behavioral health, not just on the technical professional space, but it often isn't just in our heads, the things that are happening. It's very visceral. There's a lot of stress. There are things going on for folks. And what we try to ground ourselves in is that all of us, every single person in this room, has some connection to mental health, to substance use, to crisis, for us, for a loved one, for a neighbor, for folks in our community. And so that's where I want us to be centered today as you hear my remarks and as we begin to have more conversation on this, is always, always centering the people in the work that we do and how important it is that we continue to do the work. And you'll be hearing this throughout my conversation today, throughout my comments, is that doesn't matter the swirl, doesn't matter the administration. What matters is BHA is going to continue to deliver services in our community through our providers, through the good work that you all do and how important your work is to improving our system and the kind of care people get. And so I just didn't want to lose track of that's how we're grounded in the work that we do. So Behavioral Health Administration started out of a very good reason. People are not satisfied with our behavioral health system. The way mental health, substance use crisis work, there were 3 separate systems, 3 separate ways, and depending on where you live and who you are is how you would experience the system. And so BHA was kicked off to be able to say, let's solve for that. Let's have one administration that coordinates all those and makes those systems better. We've been through a lot of change. If you've been tracking us, Commissioner Smith is the 3rd commissioner in our short amount of time, but has brought a lot of stability, brought vision to the work that we're doing, and we've been covering a lot of ground in our work also. So I wanted to just set the stage for what the mission and the vision was in our early days. It's very rare to have a brand new state department, new administration. And so to have, for Colorado, a new behavioral health administration, at the same time, we also had a new Department of Early Childhood. They also go hand in hand. When you think of 0 to 5, early stages and brain development, it was great to have both departments launched at the same time. But we're solving for a very big issue of having long-standing systems not working, and how do we make them better? So our mission and our vision is around co-creating, and the co-create part's very important, and I'm going to share with you how community is informing our work. So the co-creating of a people-first system that meets the needs of people in Colorado, and our vision is to have all of those behavioral health services accessible and meaningful and trusted. And if we hang on those 3 words, they're very intentional and came out of community voice, which is what started us. Here's what did any of you serve on one of the task force or subcommittees in the work? So Governor Polis started a behavioral health task force that led us to where we are in having an administration. And it was a massive task force, people from all over the state. It also had subcommittees, the Children and Youth Subcommittee, and I'll share a little bit about that informed the children's plan that we have. But through multiple years of work, lots of people involved in Colorado, these were the 6 pillars that came out of that work. What are the things that we're wanting out of the system? And not just the things, what are the changes? And so to have it be accessible, have it be whole person care. There are people in our community in which they don't see someone that looks like them or speaks like them or lives like in the system. How do we help to be able to have that kind of accessibility, have people be able to speak their language, be seen, have the care they need, and that whole person part of having someone who might be showing up with a mental health issue and also has a substance use issue or a dual diagnosis. How do we have all of these work together and be accountable? How many of you are connected to some sort of workforce challenge in your work? Not enough nurses, not enough psychologists, and so the workforce piece is one of the pillars for good reason. We can have all the facilities we want, we can have all the beds, but if you don't have people to actually staff it, you can't really solve for the issues or provide the care. So these were the 6 pillars, and that still guides the work, and I hope you'll see this as I share with you what we're working on. I know we have a couple of psychologists or folks in the room. This is the behavioral health continuum, and it's okay if you don't have a clinical background. I don't either. Mine's mostly in social determinants of health. But this is a care continuum, and this is the children's one because it focuses the system of care piece is where the intensive behavioral health services high acuity part. But it's true of adults too, the same components. This is what we're wanting for people in Colorado. Anytime, anywhere you live, we want you to have the care that you need at the right level and have those 6 pillars. You can access it, it's affordable. When we think about this system and what we're wanting, I want you to think about what would be your top priority if you could change anything about our system. What would that be? So we wanted to hear from people today, this year. We wanted to hear people, not just what was informed from the task force, important and still informs the work. Several years later, though, what's still that top priority? So we went all over the state over the last 2 years. Some folks tend to think, well, you're based in Denver, it's only a Denver issue, or nope, we went all over the state, from Sterling and Mancos and places in between to hear from all kinds of communities. Also to check, and we asked them, what is your top priority? The pillars still hold true. Some of that came up. But in our community conversations, we asked folks then, what is your top priority? If we could only change one thing, what would that be? So that we can get a sense of our own prioritization for BHA. Because you might be thinking in your own work, oh my gosh, where do we begin? There are so many places, so many things to solve for. Where do we begin? And we wanted communities to inform that for us. And so I just want you to take a second to just see all the different places and the community engagement and conversations that we had. We were in libraries, which some of these local libraries are fantastic. Makes me really want to just do library tours around the state. But we were in very everyday kind of places, hearing from everyday folks about what's important to them. And so I want you to think about what was the thing that you thought would be the most important to you. And if you were in those community conversations, what would that be? Pardon me?
Being close to the service.
Being close to geographically? Yeah. Well, I think you'll be happy to hear then. Here's the themes that came out of it. And whether we were in a mountain resort community or on the Eastern Plains or in a more urban area like Pueblo, these were themes that came up. Because there are issues with our systems, the things that we're wanting to solve for, that can be unique to a community and also can be very common across the state. And so I want you to see if there are the things that you named in this. And I just want to touch on a few of them. The system navigation for sure came up everywhere. How do we actually find out where we go, what we do? We know to call 988, some of that. But if your kid's really struggling with some serious mental health issues, where do you take your child? How do I help my grandmother get the meds that she needs? How do I do these things? And the navigation piece, it was really important for people. Also the navigation part, if you're jumping between systems, how does all of that work? The transportation part comes up in lots of different ways. Either we can't get over the pass to get the care we need during the winter months, or I'm on the Eastern Plains, I gotta drive really far to get the care that I need, and that telehealth doesn't always solve for what we need. So the geography, safe transport, lots of ways in which transportation has come up. The school supports, are needed. We have really good supports in schools, and there's also gaps, and schools can't solve for everything on their own. And so how do we help our young people in schools? The coordination, some of you might have been thinking this too at different times. BHA, do you work with other departments? HICPUF, CDPHE, there's so many silos. How do you all work together to make this system more fluid for us? The housing, the prevention services. So these were the themes that came up across all of the communities that we met with. Does this resonate with the things that you might have been saying? Good. And if there's anything missing, you can let me know when we get to the Q&A. We can add it to the mix. Because you're a community too. We want to hear from you. So pardon me? Being able to pay for it. If we go back to the pillars, the affordability is really important. And when I talk about the impacts from HR1 and some of that, the funding really does make a difference. There are some things to solve for that we might not be able to do unless there's more money. Or if we get creative in how we're using our resources. And that's an option too. So we'll talk more about that. We took all of these emerging themes from these communities, and that's what is getting us to our top priorities in this coming year. And I say in this year, it's a little bit longer, about 15 more months, because the administration's going to change. We might have new leadership. And so we're very focused on what can we get done during this window right now. And we took the information, the input from communities and said, here's what's going to drive BHA's work over the next year. The enhancing access to behavioral health is still a top priority, that people need access, period, in different ways of how they can access the system. But you'll hear about that in a minute when I talk about our BOSO and Colorado LIFTS model and how we're prioritizing that. But access shows up in lots of different ways, and if you think about your own communities or family members, places you've lived, it isn't just where is my nearest place where I need to go to get the care. It can also be telehealth. It can also be juggling between. It can also be getting off of a wait list. There might be a place in which you need step down and there isn't step down. So we're very focused on access. The upright on integrating and coordinating our system. How do all the different pieces work together? How do we help make sure that if someone is needing crisis care, they're getting it, and if they don't need the crisis care, but they need other kinds of support, how are the systems talking to each other? How do we have someone with a dual diagnosis cross the systems and get what they need, or substance use and mental, how do we integrate the work? This comes back to the pillar on whole person care. We don't often just show up with one thing. If you're also showing up in a hospital for a physical issue and you also have mental, how do those systems work together and we make sure people get the care that they need? The streamlining of the behavioral health in the criminal justice system. We have far too many people getting their mental health care primarily through our justice system. And so how does it work for us to have really good services within the justice system, but also for those transitioning out? And how do we make sure that that's happening? It also works on the front end. How do we make sure that people with behavioral health issues aren't being served in a jail because of a crime that might have been committed had they gotten other kinds of care in advance of that? And so we're very focused on the justice system and the connections with that in our systems. And then utilizing prevention and upstream support, in particular for children and youth. And I'll go back to this slide. We are very focused on youth with high acuity needs. And if you're familiar with a settlement agreement that the state is under to provide better care for kids who have high acuity needs. We are also, though, at BHA, very focused on the early intervention prevention, partnering with CDPHE, with Department of Early Childhood. How can we do more in that promotion, prevention, early intervention? There's prevention that can happen and also being able to detect sooner. There are also lots of kids, young people who aren't necessarily high acuity or have diagnoses related to that, but sure do need a lot of support. And how can we help with that sooner than what we're doing now? There's also, some of you might be thinking not just in behavioral health, but prevention, period, is something that I think often people want and see value in, but we don't prioritize it. Is there enough public will to do more investment in prevention? Because the payoff might not be right away. It comes later, but worth it. And so that's what we're also trying to elevate by working with our sister agencies to be able to do that. So these are the top 4 goals within BHA. And I know you all are on the facilities and construction side and all of that. That's embedded within this because some of the access needs to be also where are the locations in the facilities? What's the kind of care within them? How does all of that work to support it? So this is where we're heading and prioritizing, and happy to share more information or go into greater detail. I spend a lot of time on the early intervention children's piece. In my role as the deputy commissioner, I lead the divisions that are the children, youth, and families, and all of those programs and services. I also have the adult teams, same kinds of services and continuum for that. And also then our BASO model, the way we purchase and deliver services in the state, and I'll talk a little bit about that. But happy to have questions about other things and can help you get the information you need. Okay, I wanted to just spend a minute on how do we actually solve for some of this. Are any of you familiar with this brand new model that BHA launched in July about how we deliver services? Okay. So I know for some of you, and the architects, close your eyes because this is not a sophisticated drawing. Might not be how you do it, but I wanted to share this with you because this is going back to those 6 pillars and going back to access and also what community is informing. We launched this new model, Behavioral Health Administrative Service Organizations, or BASOs. We launched this on July 1. All of our money, I won't say all of our money, a lot of our money is given to BASOs to then put out into the community through what's called the LIFTS network. But I wanted to share with you a couple of things about this from this slide. So we have 4 regions in the state, service delivery regions. They're the same exact regions that HCPF uses for their raise and how they do services in the state. So the map is the same. The regions are the same. And so we give money to the Behavioral Health Administrative Service Organizations. There's 2 of them to serve the 4 regions, Rocky Mountain Health Plans and Signal. So they are serving all of the regions. We give them the money through contracts and all these things, and then they subcontract, they work with providers out in the community. The big changes at BHA used to be the ones doing the RFPs and the contracts for the mental health. Then we do the contracts and things for substance use. Then we'd work with the crisis folks. 3 different things, not always very integrated. So in this model, we RFP'd and did all the good things. We have Signal and Rocky. We give them that money, and then they subcontract to this Colorado LIFTS, linking individuals and families to services. That's all of the providers around the state. And so those providers are the ones doing the services on crisis and substance use and mental health. Here's the map, same exact map that HCPF uses for their Medicaid, for their raise. I'm putting up the phone numbers. They're not very easy to remember, but the phone numbers are part of the care navigation, the coordination. It's a top priority for our BASOs in the LIFTS network to make it easier for people to access care. So these phone numbers, you can actually call either one, and they work together, and they will get the person to the right place that they need to get the care. But we wanted to make it easy, so somebody could call a number and speak to somebody to get help on how do I even begin, where do I go. These phone numbers, our BASOs will help do that. We also have online. There's millennials and certain populations that really like to just, I don't want to talk to somebody, I just want to get online, do my own search and find it. You can through our website with that too. But this is the maps, this is the service regions and what we're focused on. And I just want to emphasize a bit that it's our LIFTS network, it's the everyday providers in our communities that are fulfilling these services and helping give people the care that they need. Here's why we went to this model. Fewer steps to access the care. You can still get online, that's pretty easy, but some people don't want to like sift through and then call multiple people and figure it out. You can call one of those numbers and be navigated and get the support that you need. Streamlined process, and then also just the care navigation focus. And if you'll recall, it was one of the top themes that we heard from community. How do I navigate all these different things? Let's have one place you can call or go to and do that. And then I think the slides will be shared. So I just wanted to put in some numbers for those who might be wondering why is it so important to focus so heavily on this care navigation and support. It's because there are a lot of people trying to get the help they need, and we need to make it simpler for them to do it. So we did some projections and some number crunching on the kind of care and the numbers of folks that need it. I can come back to this if folks want more information on that. So here's what I'd like for you to know. This was a real fortune cookie note that I got, and I tend to keep them when I'm like, oh, that's a good nugget. I want you to answer this for yourself, because we're about to go into the phase where I'm going to share with you the impacts from HR 1 and from some of the things happening federally. So do you see difficulty behind every opportunity or opportunity behind every difficulty? And I'm going to share with you where we might be finding more opportunity in the midst of the difficulty. But the mindset is where it needs to begin to be able to look for it. And for some of you feeling like, oh my God, there's so much going on, and it's really hard to, or the stress of it, or hard to navigate, and the uncertainty, all of that is true. And we're trying to control for the variables that we can control, and it gives us space for the things we can't control. And I'll share some of that with you. And if we, at the very beginning, we started with people still need care every single day, round the clock. People in Colorado need care. And so for us to be distracted or spread thin or dealing with some of this stuff takes away from the focus of the care that people need. And so we want to focus on that. How can we keep making the system better regardless of other things that might be coming up or distracting us or needing to attend to? So there's a couple of things for those, anybody like political wonk, like getting into the weeds, so maybe not. But I wanted to share a couple of important things coming up, because money was mentioned as one of the things somebody mentioned about, well, if there's no money or if you need money, how do you get the money? So there's a few things coming up for BHA for all state departments, and that's the Joint Budget Committee hearings. So the governor has put out his budget, if you saw that. The JBC reviews that budget, and we meet with departments, and they walk us through our budgets and make sure that it's all adding up, that the things we're spending our money on as a state are the things we need to be spending our money on. And so December 5th is when we hear from the JBC about the questions they have about BHA and how we're using our resources. And then on December 16th is when Commissioner Smith, myself, a couple of others meet before JBC for our hearing. And we also can then share more information and answer questions and all that. All of that is public. You can listen in, hear what's going on, true of any department. So just an encouragement. The public can listen in and hear things and stay tuned with us and hear what's going on with those proceedings. But it's a very important part of how we fund our behavioral health system and the kinds of priorities and things that show up in our budgets. Our budgets are our values, true of your home budget, true of the state's budget. And so how do our values show up in our work? How does this information from communities show up in our budgets and in our work? And so the first dose of that comes with these hearings too for BHA. Okay, I want to share a little bit then of how we're navigating these turbulent times. So I'm highlighting a few things and can go into more details. But of the things happening with HR 1, I'll talk a little bit about the federal climate and then talk about the state climate. The impact on what's coming with Medicaid is significant. And for the Behavioral Health Administration, our priority populations are the uninsured and the underinsured. And so when you think about Medicaid and the things happening with Medicaid that might mean people won't stay on Medicaid, those folks might become then part of our safety net, become part of how Behavioral Health Administration supports Coloradans. And so this population, this will be expanded. So under Medicaid, there are changes coming with work requirements. Lots of folks on Medicaid work. But there are work requirements that will be added, not right away. It'll come after the midterms. But the work requirements and having to prove that and file paperwork and do all of those things might mean folks are disenrolled then from Medicaid. We also have other things with Medicaid in which folks are going to be the match changes. There's going to be prioritization that needs to happen. And so there are going to be folks rolling off of Medicaid that then we will need to provide services for. That's coming. We also have the shutdown. One of the parties' conversations was around insurance, Affordable Care Act, and then the subsidies being there so that we don't have to pay more if you're on the exchange. If those subsidies go away and the rate hikes are coming, true of private insurance too, there will be increases, and there usually are. There are going to be people that have been using the exchange for their health care that will no longer have it, that can't afford it. So if they're having to make hard choices about diapers, medicine, food, how do you help pay for these increased health care costs? They might choose not to be able, or they can't even choose. They flat out can't afford it. So keeping our eye on the Affordable Care Act, on the subsidies, on the exchange. Lots of folks might be coming off of that, not having health care, and we need to provide support for them too. So we have that with private insurance and the health care with that, the Medicaid population, and then we're all, I'm pretty sure, aware of the SNAP benefits. Those might be resumed now that the shutdown's over. It will take time. Food banks will need time to restore their supplies, all of that. There was a disruption with all of that. But keeping our eye on that too. If we don't have people being able to eat, it has very big implications, obviously, and keeping our eye on children and how they get their food, the kind of nourishment and brain development and the things associated with that. I also wanted to share a bit on the public health department and changes within CDC and SAMHSA and things happening with them. We have a lot of experts who have been dismissed from their work. And so where we've been getting a lot of good data, trends, being able to be informed about things like vaccines, and that affects people's health, including their behavioral health. And so keeping our eye on that, the diminishing trust in these advisory committees that help inform then the kind of care that people get. We have staffing decreases at the CDC and also just a distrust of science. And then we have a lot of termination of public health funding. And that also comes back to the person who shared about money. So if we have in the public health realm, diminishing of the experts and the science and the things driving the work and the people to do the work and the funding to support it, that has an impact on the behavioral health system also. And then potential changes in terms of just the grants themselves. So at the federal level, we have all these different departments that have populations that might become uninsured and underinsured. And on the current budget of the Behavioral Health Administration, how do we help make sure that those folks get the care that they need? That is a concern. And we're in a state budget deficit, and the governor presented a balanced budget, but we're mindful of that too. So how do we help prioritize and think about how to support these folks? There's a piece to this that I want to emphasize too, and that's the final bullet on the potential changes. There are executive orders that have come out that also impact our work. And so while we're keeping our eye on SAMHSA funding, it's the largest portion, it's a third of our budget, a quarter to a third of BHA's budget. There are strings attached to funding. Of course there is. It's true of any kind of funding. There's always strings attached. But through these executive orders, some of them impact particular populations, some of them add restrictions. So if we agree to take the money, true of every state, not just in Colorado, if we agree to take that money, we agree to the strings that are attached, the provisions that we need to fulfill. So there are, states are suing the federal government based on some of the executive orders, and some we're not. We're accepting, and we do them. But we need to be mindful of there are now new strings attached to some of the funding or populations that we might be dictated to not serve. And in a climate in which there are also populations that are just afraid or not getting care. So there were changes to 988 regarding LGBTQ plus people and the way they can access. There used to be a specific line with therapists that can help, and some of that changed. People can still get help through 988. Please hear that, but there are populations of that, or folks who are undocumented, or people that are fearful of accessing services that they are eligible for and allowed to, but a fear factor, if they do, they might jeopardize somebody else in their family or a loved one, and so they might not seek the care that they need. And so when you think about it as holistic, whole person care at different places in our systems where they should be integrated, where we're trying to improve it, we're also seeing decreased funding, more populations that are going to be in need, kids not getting the food they need through the SNAP. And so there's just all of those that we're keeping our eye on at BHA. And when we think again about the uninsured and underinsured, and I say under if there are some things that your private insurance won't cover. And so BHA looks at those gaps and says, is that a place where we can help? And when we think about those populations and that getting even bigger under some of the things that are underway and coming, then those are the pressures. So I want to share a bit then. Yes?
Is BHA working with the insurance commissioners to make sure that if companies are issuing policies in the state, they're covering more of these behavioral health concerns?
Great. Can you all hear the question? Should I repeat? BHA definitely works with Division of Insurance to do that. And there's, all of us are working together in that way. And it's really challenging. So I think they're doing their best to manage that. And certainly the subsidies and the things coming relating to ACA, the Affordable Care Act or not, they are definitely keeping their eye on, and that will be have a very big impact on what private insurance will be needing to do or not do to help with that. Yeah. Oop, let me go back. I want to talk a little bit then at the state level. And also to keep in mind, Colorado is state regulated and led, but also counties do a lot of the work and where a lot of the care happens. So I want to acknowledge, too, there's a lot of pressures on counties. And the partnership that the state has with counties, the kind of work we all do together, but all of this then has an impact at almost every level then. No one's immune from what is underway and what's happening. So we have all of the state departments were asked to reduce our budgets 2.5%. That's what you'll be hearing at the JBC, the Joint Budget Committee hearings. Every department had to reduce. So where there are things where we would want more money and to make more investments, we were asked to reduce. And that's part of getting to a balanced budget, which Coloradans want, and we have to do. But state departments' budgets are shrinking. And then the state funding challenges are further affected by the Medicaid coverage, the kind of benefits that are being offered and how that changes. The way Tabor works and how we have to fund pre-K to 12 and Medicaid, if Medicaid continues to be rising or the changes in that, that's a substantial part of the state's budget. And so we all keep our eye on Medicaid and how that works, and also to see what's left and how else that impacts the rest of the state budget. Again, the pressures on counties to deliver their services. We are also having to make some very hard choices. And so with the state budget shrinking, with a potential increase in volume and need, every state department's going to have to make some very hard choices, and have been, about the kind of services, the kind of things they can continue to do or not. And we have to get really creative, because there are things that we just need to look at differently. That's that fortune cookie piece. We need to look for the opportunities and not just the difficulties that are in front of us. And it is difficult. There's no getting around it. It's going to be very challenging. And so I want you all to know, as you're thinking about how you work with the state or the things that are coming, this budget funding piece and the population's impacted by both the federal HR1 and executive orders and the things coming, in addition to then the impact on the state and how we respond. All of that plays out. And then at the county level, they get a lot of state and federal money too. They also deliver services. They also have their own mill levies and things. But at every level, it's getting more challenging about how it's all prioritized and the kind of things that we're going to be doing. Okay, I want to share a little bit about then some new opportunities to be thinking about. So there are still some new funds. There's a rural transformation grant. Medicaid or HCPF in our state are the ones leading it. Most states, Medicaid office leads it. But the rural transformation grant focuses on infrastructure, data, facilities, things in rural communities, in light of the pressures on rural hospitals, the number of them that are closing. How do we help provide services in rural communities still? So we have our eye on that and working with Medicaid. There might be other kinds of funding available, even in a very hard environment in which funding is an issue. We're also encouraging people to look at new partnerships. And we've met with providers and communities, and they're all asking, how is this going to work? How do we keep our funding, or how do we keep doing services? And an encouragement is to look for new partnerships, the new way of doing services, things that can be integrated or streamlined. How can you work together with some partners you might not have worked with before? Get creative in thinking about that, and BHA is doing the same. Are there different ways we can work with our sister agencies, new partnerships that we can help foster? How can we get creative with that? Are there new approaches to the services, new approaches to your own priorities, or to how providers are doing that? So if they try to expand and take on additional services, what are their key primaries that they do really well, and maybe they can partner in another way to cover some of the other things. So it's just an encouragement that we have to get really creative, think differently about how we solve for some of these problems. How can we help make the most of what we do have so that people are served in the best way that we can? And that's what we're looking at. I wanted to also share an opportunity of, like every state department, BHA has ways in which community engage in our work. And so not just us going to communities and asking for input, but there are advisory councils and commissions and boards. And if any of you are interested in any of that, please connect with me, and I'm happy to help find what might be a good match or how best to do that. There are also ways in which the public, we're required to have the public inform the work, not just that we want to, but things like rulemaking and how do we write the rules, regulatory spaces. There are public meetings that BHA holds, and anyone is welcome to it, and you help inform the work. So I was speaking with a woman who's an architect and saying, how can we be involved in all the rules, regulations, licenses? There's so much to navigate. And at least in my 2 years at BHA, I haven't seen much engagement or involvement in those ways. Probably on us, not on you all, but I haven't seen much engagement from your kind of industry or the way that is engaged in the work. And yet these licenses and rules and the things that impact your work, you have a say in, and we want your input. We aren't architects. We aren't in construct. We don't do the kinds of things you do. Help inform the work. Help us write it in a way that makes sense. And so we always post on our website upcoming public meetings, ways to be involved, and you can log in from your office or your home and join in and give feedback and written feedback. There's lots of ways to engage. So just an encouragement that you can help inform the work and be part of making all of this better. And we'd love to have more engagement from your industries and the fields that you work in. Bless you. I'm going to pause here in a minute and open for Q&A, but have any of you heard of Eddie Jaku before? The play about him was just at DCPA, The Happiest Man on Earth. He is a Holocaust survivor. At 100 years old, his memoir was published that he wrote, and then he passed at 101. He has a TED Talk. If you're interested in seeing that, he was encouraged to tell his story as hard as it was. And it's an astonishing, astonishing true story. I wanted to wrap up with this quote of his. He made the decision to be happy, and happiness is his revenge. And he says this himself. But the choice about being happy is such an important one. And what I wanted to leave you with was one of his quotes around, perhaps you don't love your job or you work with difficult people, you're still doing important things, contributing your own small piece to the world we live in. We must never forget this. Your efforts today will affect people you will never know. It's your choice whether that effect is positive or negative. You can choose every day, every minute to act in a way that may uplift a stranger or else drag them down. The choice is easy and it's yours to make. And I offer that in not just with his astonishing life and all that, but we're in a moment in which we do have choices, and we are fortunate if we do have a choice. And for those of us in this space with behavioral health, there are people that need our care and don't have a choice. And we have a way to influence that through our design, through our construction, through the way we influence systems. I do in the state, and how we do that work and put out services and things into the community. And I remind my staff that also. There are very hard things happening, and there's a lot of uncertainty. And yet we need to ground ourselves in the choices we can make every day to make someone's life better that we don't even know. So how do we uplift Coloradans? How do we uplift our folks? How do we still find the thing that we can be doing every day that can make that difference? And that's what we can be grounded in and focus on and do something. And we're fortunate to be able to do something in this time. And I'm really honored to be able to do that and to help people. So with that, I just want to then open the floor and have time for some Q&A and see if you want more information or share insights, whatever you'd like. So I'll pause here. Yeah.
Sorry, I spoke for a while. Hopefully this isn't too long a question, but the state, the counties, you mentioned the counties, and the county sheriffs and the jail systems have a high percentage of people with mental health and substance abuse disorder issues. They're starting to discover that that's costing them a lot because there's a lot of repeat offenders annually. They're coming through their system that costs them a lot, for daily care for those folks. So they're starting to understand that as an opportunity, they can save cost. If they identify those people early and get them into a behavioral health therapy program where they can't get therapy in the jail. But I think there's a block, I'm not sure what the right word is, getting commissioners, to recognize, to spend money in order to save cost over here. They need to spend a little money on this program, save cost over here. So I'm wondering is if the state has any communication going on with county sheriffs, or networking, if there's networking in any way happening there to try to lift up some of those programs.
Could you all hear the comments around the, okay. Yes is the short answer, and BHA has contracts, relationships with sheriffs in doing jail-based services. There's lots of ways in which that can happen, and if, as I noted in one of the goals for BHA, there's a lot more we can be doing around supports within the criminal justice system at all levels. And so that's a priority of ours, and we are working with sheriffs to provide services also, and there's more to do. So the short answer is there is a lot of work that's being done and helping figure out what are those gaps, what's more on that prevention side we can be doing, and when they're released or transition out, what's the kind of support and care that's needed for those folks too. So we definitely have our eye on that, and it is a priority. The conversations are happening, and it's one of those ways in which we have to get creative in an environment where there's just limited funding and support, but it's definitely a priority. I'm glad you brought that up. Thank you. Yeah.
If you've mentioned this, I apologize, I might not have heard it, but regarding the stigma that's been out there about, you're gonna go see someone to help with, your mind and things like that. I know when we work with people, we should be talking to each other and, face to face is best, right? So you can see their interactions and their expressions. But like with your time at BHA, what are some things that you guys are doing to kind of help bridge that so that it's okay to, it's not the stigma's not there to go see a therapist because they are very helpful. I mean, I love this quote. We're all dealing with something in some part of our life, but it just seems like there's still that stigma. And how do we get past that?
Yeah, it's a great question. It runs segment, and also a good one for when we're meeting on our panel of how they do that in the local level. There are several things that BHA is doing. One, we have a Tough as a Mother campaign that does outreach for pregnant people to be able who have substance use issues to be able to get support, and there's a media campaign, public campaign around that. We do a lot with 988 and outreach to reduce the stigma and make it easy to call and but to make it so that folks might want to call. We also do a lot with iMatter and have it be school-based, and the things we're doing in schools to help build the capacity within the school setting to decrease stigma and improve then the accessibility for young people to get care that they need. We also have recovery cards and outreach for folks with substance use issues where we've asked you all, anybody in the public, to write a card of encouragement and to be able to use that in recovery homes and recovery settings. And the stigma part, though, is still very real. It comes up in smaller communities where people go, oh, I can't go to that clinic or that support that I need because they'll know the truck I'm driving. They'll know that I'm parked out front. And so there's outreach that needs to happen at a more local level, too, in which neighbor to neighbor, farmer to farmer, that the person that can be that influencer can help diminish that. But I will say it's an everybody effort to be able to reduce the stigma and to be thinking about in your own way, how can you help minimize the stigma in your own communities, in your workplace, in your family. It has to be everybody all the time. It's a culture around stigma. And we create that culture. We're all part of it. So BHA is doing its best and has targeted efforts and things that we're trying to, and being out in community and being at places that aren't typically where you would talk about it. And we need to be talking about things to be able to minimize the stigma. We've done outreach in football games. We're at festivals, not just the things that are about a recovery march or a thing specific. We're at everywhere, trying to be in everyday places to help minimize that. But I invite you all to be part of that and to help us with it, to help minimize that for the folks around you. And I'll repeat again, we might not know the person that you're working with or that your neighbor or whatever is struggling or has issues. So the more we can talk about it and normalize that is good. Yeah.
When you speak of opportunities, how much work is BHA doing with private or, shall I say, charitable organizations, whether they're private or faith-based organizations? There's a lot going on in that realm as far as trying to provide services as well. Is BHA coordinating, or do they get involved in that?
Yeah, that's a great question. We have, I think we can always do more. So if there are folks that you think we should be connected to, please let me know. We have staff that do community engagement and help us to connect in communities around the state, including faith-based, including smaller charitable organizations, farmers, unions, whatever it takes. We want to build connection and have people engaged in the work and us to be able to help provide them with what they need. Information, education, services, whatever that is. So one other, some of the steps we're taking around that, aside from our own outreach and that, is we have each of the 4 regions for our BOSSOs and the LIFTS networks have a regional council. And so they're everyday people who live in the regions who are helping to inform the way that we do services in their communities. And so that's a way that we're also asking them to help us identify What are the places, the people, the organizations that we need to connect with that can have recovery cards in their lobbies, that can do outreach, that are meeting with young people, that in their faith organizations can have us have some connection to. So just an encouragement to let us know if there are places that we haven't been or folks we should be connecting with, and we want to do that, absolutely, and have done outreach already, but I'm sure we can always do more.
So in one of your first few slides there where you listed the priorities that were identified through your community outreach, I didn't expect to see housing listed there because it's not something I typically associate with behavioral health. So what does that priority mean to BHA, and how are you addressing that need for the community?
It's a great question around housing, and also interesting that it isn't an obvious connection about it, which I think is true. It has shown up in lots of different ways. Housing has shown up with a workforce shortage. Can't afford housing, can't hire people to work here. Or they're driving long distances. And this is mountain communities and other places. They're driving long distances of where they can afford their place to live versus where they can work. And so that gets in the way, too, of workforce and then being able to provide the care they need and recruit the staff they need and all of that. There's also basic housing in terms of if you don't have housing that is secure, you have a hard time then having your kids be able to, and your family, access the services in your own community, or to have that kind of disruption means you might not be able to then continue with your provider if you also have unstable housing and then need to move to a different community. Then you start that process over and try to find somebody else and how that works. And the stress and the financial burden, the unaffordability of housing is a top issue. And so it's pervasive across any of it, is how can we have secure housing? And that be a foundation for how people get the care they need and the community to build and the support. And so it's just central and has shown up in those different ways. In addition to recovery houses and other places in which BHA makes investments. Yeah.
Are there any community programs that you have seen creatively in the different regions, and you say, this might really be something to bring to another region and do that teaching of what's happening between the different regions?
I love that question. It's as if you were at every community conversation we did, because we asked the community 3 questions, one of which was, what's your top priority? Another one was, what's a success story from your community? And is there a success story we want to know that we could replicate, that we could expand or do those things? So in every community, it was great. There are success stories, not all of them that could be replicated, but also made us want to be more intentional about how we do it. And so one of the examples is when we were on the Eastern Plains and talking about how concerned that folks are in their community of farmers will give their right arm for you. Your neighbor will do anything for you. It's really hard to ask for help for themselves. And so we heard of strategies in different communities in which how do they use the pastor in the local community to do that, or how do they use other farmers or places where they meet to help break down stigma, to help name some things, to be able to provide support. There were also examples of folks being released from the justice system and left to their own devices in some cases about their own transport and how they get to the community they need to go to, and the ways that smaller communities solve for that. And so there were examples, and larger ones too, around the way that they partnered with different types of facilities and things to provide a more holistic care. So we took those success stories and we're trying to vet to see where else can we replicate, what other communities might be similar, how can we connect people in different communities to talk to each other to help solve for some of the things that we were hearing when we were meeting with folks. And so thank you for bringing that up, because it was interesting and wonderful way for folks to also acknowledge some of the things that are really working that they were doing on their own and troubleshooting for, and then us helping to connect with other folks to do it. Yeah. Yeah.
Can you talk a little bit about the prevention services that are available and what can be done to enhance them?
Yeah, great question around prevention. There are several programs that BHA funds. Tough as a Mother is seen as that too in terms of prevention. But there are things that we do on the 0 to 5 age range that helps support families, helps provide care, therapeutic services, things in that younger age range. We partner with CDPHE, and they do the more traditional primary, secondary prevention. Think of smoking cessation. Think of gun safety, things like that. So we partner with them and with public schools also. One of the things that we've been doing, had done, and then the legislation changed with budget cuts, but we're continuing it in a different way, is doing screenings in schools. And there was a 6th to 12th grade mental health screening tool. And the screen is the kids in a class, and parental consent and all the good things. But they go online and they're in class and they take a screen, and based on their score flags whether or not a child needs more support. And we did that last year with several school districts, and we make sure before they do that, we have the things in place and can respond. And there were several children that never would have been flagged had it not been for that screen. They were great students, no trouble, and yet had really significant issues going on. And so we try to do, and we've been that program ended with that legislation, but we have a funder that has supported it, and we're doing it still in this coming school year. So the screening tools, partnering with early childhood in the ways that they're connecting with their families through pre-K providers. And so we're targeting in that way. There is a lot more work, though, to do to make bigger investments, is our opinion, to make bigger investments to have more intentional and just more services in that early stages for young people than to only be and we're not only focused, but there's a lot of emphasis on the high acuity and justified. But there's a whole lot of kids that aren't diagnosed with things that would be high acuity, and we want to make those investments to do it. And so how can we partner with schools who have also seen a lot of reduction in funding and support through the Department of Ed, but how do we use school settings, pre-K settings, partner with CDPHE and with our work, and more integrate better the resources that we have to target that age range sooner. Yeah.
Can I ask, so can you expand a little bit on the coordination of inpatient support that you do, just with the number of beds and anything that happens on that inpatient side, which is the absolute opposite end of what we were talking about just a minute ago?
Yes, it's no surprise probably to folks in this room that the coordination of that is one of the top themes that came out of the work. One of the primary things that we heard pervasively in my 2 years here and in Commissioner's first year is that there aren't enough beds, there aren't enough places for kids. Is that what you're talking about?
Yeah,
in that?
kids and adults, yeah.
Yeah, kids and adults. So, so one of the tools that we're working to improve is we have a client care search tool, affectionately called Bed Tracker. And the notion is, like, we know how many beds are licensed, regardless of who's doing the license. We know how many beds there, but are they staffed, and at what level, what ASAM services? That's the thing we don't know at any point in time on a given day. And boy, would that be helpful. If you're trying to do care navigation, trying to help with somebody with step down, where is the staffed bed at this level with these services that I can then reach out and get someone into? So have been for months refining that tool. So right now we have, it's not available. The version of it is available, and there's that, but we're enhancing it. And so we're trying to also get real-time data, and we're starting with the things that BHA licenses and manages, those beds with those providers and facilities. So we're working on that tool to get that refined, and also in partnership with CDHS and HCPF and others for their beds and their services and capacity. We would like, in the ideal state, to have every bed in Colorado, regardless of whose it is and who pays for it, whatever, for somebody to be able to go to that tool and click on it and find the facility and the right level and be able to have folks go to that and get care. And so that's one of the ways we're trying to improve the coordination of, is by having a better tool and better information to be able to make available to people. We're also working on, this is very kind of in the weeds, but digitizing the CANs, which is an assessment tool. And right now, providers are having to scan and fax it in or send it. It's handwritten. How can we help improve that process and also have the data to then analyze what is coming out of these assessments and where else can the state do better, knowing those pieces. So we're working on that too. We've also worked a lot with HCPF's RAISE and with our BASOs, and how do they work better together? If you have someone that isn't Medicaid eligible, that is going to a provider with their RAI and needs to be, have the support and care through us and our funding and our facility, how do they work together to make sure that that's happening? We're trying to decrease the number of handoffs that have to happen for someone to get the care they need. And so we're very focused on how all that happens, and including with counties. It's hard, too, for them on these handoffs, and you might have someone in child welfare, and then the kid's not in child welfare, and then they're Medicaid, but then they're not on Medicaid, and how do we help make all that more seamless? And so that's still a work in progress. But we're working with the departments, we're trying to improve our tools, and we're also have an eye on decreasing the administrative burden of these providers who have to enter a lot of data or do a lot of, so how can we help minimize that also? So they're also not having to repeat things that they've already done and just submit it to a different department. And so we're looking at all of those pieces. Any other questions, or you won't sleep tonight? Yes.
Not necessarily a question, but maybe a comment to put on the radar. I'm Mark Wright. I work at Inver Health, and we tend to work in the space of both on the civilian side and the non-civilian side, in line with the question that was posed earlier. And just, it's something we've struggled with for decades, quite frankly, to try to solve from a legislative standpoint, as well as, regulations, 2765, and oddly enough, when somebody gets incarcerated, right, it's a different world. And so those regulations do not apply. And some of the barriers to care, focusing on the individuals, coming up with a solution, maybe outside of the Hopkins kind of waiver kind of mentality. I think there's opportunity in that space, because arguably our jails are becoming the de facto, dare I say, safety net for people who are not able to get care anywhere else in community, and the regulations from municipalities, judges, what have you, struggle mightily in terms of navigating, holding the short-term certs, what have you, when somebody goes into that space. And so we've taken a look at that over the decades in terms of how to, do that crosswalk. And I guess I'll issue a personal opinion. We've not yet been successful in that space. And so I just put that out.
Yeah, thank you for bringing that up, because we've mentioned a few times the need for jail-based services, the need for helping folks as they transition in or out, the involuntary commitment. You're preaching to the choir in that way. There are definitely things that we need to get better, and not always necessarily legislatively. There are lots of different ways to go at it, and you mentioned this with regulations and some of that. I will encourage you all to be, if you're not already, to be involved in our work on rulemaking or to attend community sessions we're having to provide that. I'm also happy to connect you personally if there's an expertise that you have and want to find the right way to provide that. And I think in this, there is a lot of work currently happening on that process. and improvements that we want to be making in this legislative session. And also, one of our top goals is around how does the behavioral health system work with the criminal justice system and be better, that we should not be having people have that be the criminal justice system, be that de facto as you described. And there's definitely a will to change that and to provide the right resources to look at that system and process and to improve that. And so we are actively working on that coming into this next session. But there's also lots of things that need to be improved, and we are open to hearing from you on the kinds of things that we need to be thinking about. Yeah.
Lastly, when the initiatives don't go through, is it mainly because of budget and funding?
Which initiatives are you?
Just various items that you guys present and then they don't get like accepted. Is it mainly because of budget?
That's a great question. I think you're talking, in the legislative session, if something doesn't get passed, what's the reason? It can be lots of reasons. So their budget is definitely one of them. So for this year, we had departments had to take budget cuts. So we were not submitting things that would require more money. And also, though, not just in this year, there are also pieces of legislation that are really good and also just don't make it to the finish line for lots of different reasons. Maybe there's also legislation that needs more work, and so it also doesn't get passed. But it can be things like stipulations within the bill that still need negotiated. Or there's a budget impact and they do an analysis with pieces of legislation. What's the fiscal impact if this happens? There might also be other kinds of impact that doesn't have to do with money, but that the state isn't prepared to do, or lawmakers don't feel like that's what needs to happen. Sometimes bills are run to solve for problems and they don't make it to the finish line, whether or not they're great ideas or not, but there's also other ways to solve for problems. And so other bills are prioritized or done. So there's a lot that goes into whether or not a bill will eventually get passed or not. Sometimes it's money and sometimes it's other reasons that it doesn't make it. Yeah. Yes?
Since you mentioned sleeping tonight, related to your work, what is the one thing that keeps you up at night?
It's the one thing that keeps me up at night. I think in general, every day I ask myself, have I done enough? And so there's some things that I don't necessarily lose sleep. Like I try to get good sleep so that you can keep doing the thing. But of the things that ruminates, or the stuff that when I get home still is like, have I done enough? And so I try to rethink, like, are there things I could have done differently? Or is there something then tomorrow or going forward that, you know, once you've processed and all that, can try to do something differently? Yeah. Well, very good. I think we've hit our energy level. Oh, are you going to close this out with one last?
Yeah, we got a few minutes until,
Yep.
I'm like this, I'm trying not to pile onto the jail-based services until Mark jumped in there too, but there are a couple things that we're working with a county. They're working on getting a program together where they basically do a carrot and stick thing for people that are pre-sentencing, where they identify them as potential candidates for a program, for a behavioral health program. And then they put them in the program for 60, 90 days, whatever they end up doing there. And then they can expunge their record and they never have to go in front of a judge if they complete the program. If they don't complete the program, it's back in the jail. Two of the things that seem like they're issues, that one of them is, these are sheriff's departments that are putting these together, and they don't have the professionals, the therapists and people that are on that side of the behavioral health side to hire, probably, but they also don't have them in-house to work on the facility design, so we kind of help them with that. But the other one is kind of what I see as a gap between substance use and behavioral health, where they actually pulled the substance use piece out that we had in initially, because I don't know if it's regulatory, we're not having the people to manage that in their group, but it takes away from the holistic ability, to treat these people that are the repeat offenders that are coming through so that they can, and they also have a great program for people that exit their program to get them back on their feet. But there's a gap there, I think, between behavioral health and substance use that needs to be addressed. I guess I'm not asking a question, but I'm just kind of putting it out there. That seems like there's some things like that going on that kind of create barriers, to getting it done right.
You captured it very eloquently, so you did a good job with that. I will pile on then on your piling on around that. I will say it's a top goal of ours for a good reason, in that one community has named this and we need more supports. But for the reasons that you're describing, the criminal justice system in and of itself, we want the public to be safe, and we want the folks that are there to also get the care they need, and for those transitioning out to have that. So in and of itself, there are a lot of barriers and a lot of investment that's needed, and really good programs that are happening. And similar to just the larger behavioral health system and why BHA exists, is that we've had piecemeal, program by program, or in some counties and not others, or some things statewide and some things not, and true of criminal justice system. You have some counties with some programs that are doing this, and some that are doing that, and some that have staffing shortages, and some that have other kinds of barriers. And how do you help problem solve for all of those different pieces to make that system more holistic in the way it serves people and protects the public and does the things that it's supposed to do? So it's, again, a top goal of ours, and we have services still, jail-based services that we're doing with most of the counties. They have additional programs they're doing. There are things we need to do around competency and all of that part of it, the way that young people are being served and how that works. So there's so much to do within that in and of itself, and you've done a nice job of just capturing what are some of the barriers to be able to provide holistic care, to get them the services when they need them, and have it be more continuity across the state and in every county and at the level. So just an encouragement. There's a lot of work still to be done on that, but we do have support from sheriffs and others. All of us know that there are things that need to solve for. And that's sometimes the biggest hurdle. Is there the public will? Is there the will from those involved to do it? Is there the desire to, and there is. And so that's a great place to be, is that there's a lot of folks who want to improve this, and figuring out all the different ways to make that happen is one of the charges of BHA, is to coordinate across these systems and to help us solve for that. So it's good thing we're working on the thing that you're so passionate about. Okay, I'm going to be around in case you think of something else or want to ask something. I really appreciate your time this morning. Please stay for the panel that comes up after the break, because then we'll be hearing from the folks on the ground doing the really good work and what's ahead. So thank you.
All right, on to our second part of our morning here, our panel's discussion. So I'm Trevor Craig. I'm one of our healthcare leads with Turner Construction, as Kat mentioned earlier. We've got, as you can see, we've got one too many pictures on the slide here. Jeff had a emergency this morning, go figure, in the healthcare business, right? So we've still got a great panel in here. So we'll start off with Julie Lamb is the healthcare lead for over 13 years experience advancing high quality, data-driven behavioral health as project director of the Certified Community Behavioral Health Clinic initiative at Aurora Mental Health and Recovery. She leads system-wide transformation to strengthen population health, advance trauma-informed practices, and promote whole person care, elevating the patient experience and improving outcomes. Former clinician and current president-elect of the American College of Healthcare Executives and Rockies, Julia bridges from frontline insight and strategic leadership to drive innovation in Colorado's behavioral health system. Monica Lentz is a proud Colorado native and Hispanic leader serving the Senior Administrative Director for Behavioral Health and Correctional Care of Denver Health. She oversees a broad continuum of behavioral health services across hospitals, jails, and community settings, guiding teams through complex funding challenges, evolving regulations, and increasing community needs to ensure Denver's most vulnerable residents continue to receive compassionate, high-quality care. With nearly 2 decades in healthcare leadership, Monica is known for driving behavioral health care. She earns the MBA from Regis University and her bachelor's from Metro State. A mother of 3 and active volunteer, she brings the same passion for wellness, adaptivity, and growth to both her work and her community. And then final, we have Dr. Casey Wolfington Angel is the Vice President and Behavioral Health Clinical Services at Vail Health, where she founded and developed a comprehensive continuum of behavioral health and spanning outpatient, 24/7 crisis and mobile response, integrated behavioral health, and Colorado's newest inpatient psychiatric hospital, the Pre-Court Healing Center. Under her leadership, Vail Health has experienced behavioral health across equity and affordability across several rural mountain communities. Dr. Wellington also supports clinical health work within the Vail Health Behavioral Health Innovation Center, advancing research, training, and emerging models of care, including psychedelic-assisted therapy and innovative behavioral health treatments. She serves on several state and local advisory boards focused on health equity, clinical strategy, and behavioral health reform. She is also the founding training director of the APA-accredited predoctoral internship program, the Colorado Psychology Internship Consortium, which is Colorado's only APA-accredited predoctoral internship program. She's passionate about health equity, ensuring access, and changing the perspective on behavioral health from innovation and prevention. Please welcome our panelists, and Kelly, take it away.
All of that to say, what an incredible panel. Let's welcome them. Give them a little love this morning. This is going to be the best part of the brain candy this morning, is hearing from these folks that are very impressive, the work they do, so important, really good partners with the Behavioral Health Administration. So I'm really honored to be moderating the panel. So you're with me a little bit longer this morning. But we're going to start off with hearing from you all what resonated with you from the comments that I made this morning or from the questions from the audience. What resonated with you, stuck out for you? Do you want to kick us off, Julia?
Sure, you bet. I think there was a lot, both in what Kelly said and then also in the thoughtful questions that you posed. And I think one of the first things is that quote that you mentioned at the end, when there is so much uncertainty and challenges that we're facing, I really think that coming together with my partners sitting up here as well and with you all in the room is one of my favorite pieces of this work. And so I just want to recognize you all as well. And, you know, in behavioral health with people that are serving and out there doing this work every day, creating spaces that work to do that work, that are trauma informed, et cetera, that feel comfortable to our staff, to our clients, that is no small thing. So that was one of the things that I took away. But then also just pragmatically in thinking about these changes and navigating uncertain times, I think the first thing, like Kelly said, is remaining grounded and really being thoughtful, strategic, et cetera. And so in thinking about some of these things, I just wanted to share maybe a few of the things that we're working on, particularly as it relates to some of the Medicaid changes, et cetera, how we're operationalizing some of these tactics so that our clients don't slip through the cracks. So Aurora Mental Health and Recovery, we are a comprehensive safety net provider. And as such, we serve all, and that is built into our mission. It's built into our values, et cetera. So even as we navigate different executive orders that come out and all these different changes, we're remaining grounded, thinking through what can we do to help our clients. One of the things that we're doing is proactive reauthorization support. So working closely, like Kelly said, with our counties to share Medicaid reauthorization deadlines and integrate those into our EHR. That way staff are able to know who needs the support and when do they need the support ahead of them losing their coverage. So really trying to take that proactive approach. I would say also leveraging vocational services to really think about those work requirements, support our staff in those work requirements, as well as documenting exemptions for behavioral health conditions. And I think I would also echo that this work is not easy and it's ongoing. And we're developing a work group right now to think about the uninsured population. We're already seeing a rise in referrals from uninsured and underinsured. And so we really want to think about and use data to understand how and where these people are showing up, what are their needs, and what can we do most effectively, what are the outcomes, interventions, et cetera, that we can trace back to impacting this population at the most cost-effective manner. And so those are some of the things that we're doing, and always, thinking operational and strategically as we navigate these shifting times with our partners. And I would say one other thing I wanted to share, and I'm sure we'll be talking more about this today, is the idea of leaning on our other organizations. So some of the work that I oversee is our Certified Community Behavioral Health Clinic initiative. And so that is a standard that raises the standard of care nationally. So it's a federal model and gold standard, and thinking about what does that look like in Colorado. And through that, we have learning collabs. So Monica and her team and I often, call each other and we're like, hey, how do you handle this thing? How do you handle this thing? And so I rely heavily on our partners.
Yeah, Monica, do you want to piggyback since she mentioned you?
Yes. Yeah, definitely. So partnership is huge. And I would say that what I took from this morning was the idea to co-create this whole person thing. We can't do that alone either. So at Denver Health, we do a lot. We're everywhere. We're not just a hospital. That's one thing that we try to share with everyone. I don't have the numbers off the top of my head, many different communities. We have lots of FQs. We have integrated behavioral health in all of our federally qualified facilities. And we also are in schools. We are in 19 schools across DPS. We have mental health support in all of those areas. We have substance support in 12 of those schools right now. So that whole person care is really, really crucial to what we do. And not only the whole person, but the whole family. Jeff spoke a little bit to us when we were prepping for this, that Children's Hospital is navigating that as well. I think that's really important, is that you're not just supporting just that person. You have to look at the environment that they're surrounded in. And sometimes their best supports and their hardest challenges come from their family. And so how can you support their families? So Denver Health, really, we lean into that area hard, and we work with our partners around us to help support us through housing, housing is huge, and especially in Denver Health. We have a little bit of the housing business. We have a building at 655 Broadway that we have transitional care there, and we partner with people to get affordable housing. We work directly with all of our community partners on collaborative efforts to transition people to the right care at the right time, because we're not always the right care. We're not always the right space, and they need to be somewhere else. Being the hub in Denver, we get a lot of people from other counties, and we need to connect them back to their counties. We need to connect them back to their states sometimes. So I think there's a lot of challenges in that space. Transitions of care is a huge challenge that we're navigating. We're leaning into it really hard to, instead of relying on the patients to navigate it themselves, we have to put someone there to help them navigate it through peers, through care navigators, and creating a centralized system. So that's what we're trying to do at Denver Health, and I really felt that you addressed a lot of that amazing efforts from the BHA, and we're trying to collaborate directly with you because we know we have to be at the table. So.
Well, humble brag, a friend is a nurse practitioner in one of your school clinics. And so just lots of ways in which behavioral health shows up in the integrated care of a school setting where the students might not know that's any different. Of course you'd get care in your school, where for some of us that never happened. That just wasn't how we got the care that we need. So thank you for that good work. Dr. Wolfington Angel, what resonated with you?
Well, I feel like you set me up really well there talking about that. For me, it's the focus on how we address accessibility. I live in Vail, Colorado, in a rural region, and oftentimes people don't think about it as rural because we have ski resorts, we have Vail, we have Beaver Creek, we have a ton of tourists that come to us every year, but we have had consistently a behavioral health provider shortage area, as well as a behavioral health service shortage, which means that the type of services that have been provided locally are very, very incredibly minimal. So people face very substantial geographic barriers when accessing care, which actually meant two things. It meant, one, they only accessed care when they were in crisis, which means that the most times they were going to the emergency department and then being transported down to Denver via ambulance, or they weren't getting care at all. And so the fact is that the challenges that we have in our rural communities, it's so important to look at accessibility, not just the services that are provided, but who is providing the services. And the BHA does a really great job of looking at this comprehensively and thinking about part of the solution is services to the people in the communities, but part of it is making it easier for people to become caretakers and behavioral health clinicians and to get the hours and be able to come into the field. And that includes housing, like Monica is talking about. That includes student loan reimbursements. And it includes thinking about how we are outreaching our youth to think about this as a possibility for the future. I think that's so incredibly important. I think one other thing, because I like to have multiple answers to a question, is, when the client bed search tool was mentioned, I think a lot of us would think, wow, well, that seems pretty basic, but it's actually incredibly life-changing. So just a few years ago, in order to understand the bed availability at an inpatient psychiatric hospital, you were calling every single inpatient psychiatric hospital. There was no centralized way to understand that bed availability. And the worst part about it, as soon as you made that call and got that availability, you had to go and get your packet, which is 30 pages, and put it in a traditional fax machine and get it off to the hospital. And by then, that bed that was available could have been taken. And so that this leveraging of technology is incredible. I actually updated our bed capacity while I was sitting here in the room this morning. I tried to do it by 9 a.m. I was a little late this morning, but yeah. But at the end of the day, this is ways to leverage technology to increase accessibility so that we have less busy work for the individuals that actually truly need to care for our patients.
I love that. Thank you. Did you get the reminder?
Yeah,
Or
I sure
auto
did. Thank you.
reminder, and then they do it on their phone. So thank you. Check that box.
Yeah.
In my comment shared from a BHA perspective, the impacts from HR1 or some of the federal things going on. We're going to start with Monica. And what are the ways in which Denver Health's preparing or has been preparing for all that's going on?
Yeah, so we service over 88,000 patients in behavioral health every year, and we have over 60% of them have Medicaid, A large percentage of them are underinsured, uninsured, and we know that there's going to be somewhat a floodgate reopening. We're using a lot of actually our COVID processes to go back to think through how to strategize, how to navigate this, how can we be proactive in the preventative space. We've gathered teams from our EDs, our urgent cares, our primary cares into big, huge lean activities to understand what can we do right now to be prepared? How can we prevent someone from getting to the ED when they stop going to their PCP? What can we do more in the PCP offices to encourage them to get there? Can we create more offerings in our urgent cares? Because as you know, the ED is the most expensive outlet to hospital and in healthcare. So that's the most expensive care. So if we can prevent people from going there for a cold or for going there for their mental health concern, if we can create opportunities for them to navigate these challenges in urgent care, in their community, somewhere else, a school. The school-based clinics are huge, so making sure that we have access to those for all the kids and that we can offer all the behavioral health offerings and the vaccinations and all of that integrated care is important. So we've partnered with all of our teams. We're navigating how do we prevent people from getting to the emergency department? What do we need to put in place right now? Maybe it's behavioral health in the urgent care setting. Maybe it's other things of working with our partners, making sure that we know where can we send them? How, if we're full, where do we send other patients to? So making sure that we're working collaboratively in our community as well.
Collaboration, emphasis on urgent care, emergencies. Dr. Wolfington, Angel, what are the ways in which you all are preparing or working on this?
Yeah, absolutely. I think one of the most important things we're doing in Vail is engaging in some education and marketing materials that really counter the fear that people have as a result of the anticipated cuts that this bill is going to bring. And I think sometimes what we talk about, and we spoke about this earlier, is even the process of, let's say, enrolling in Medicaid can be so confusing, so complex and daunting that people do not engage in the process unless someone's sitting side by side with them to walk them through this piece. And the fact is, with the passing of this bill, people are afraid and they feel like, why would I even go through that? I'm not going to qualify. All of that is being cut. So I think being really thoughtful about who we anticipate will continue to qualify, and for those that don't, still engaging with our case management team and our clinical case workers, because here's all the other resources available. And so don't just disengage and feel like there's not going to be anything left for you, but how do you really show up for the community and provide the material to say, here is what is accurate and here is what we will still be able to provide.
It may add a bit, there's also in the new bill where they'd have to renew more often. Can you say a little bit about that?
Yeah, absolutely. We have really, I think, doubled our case management team in anticipation of both that this is complex. I'm assuming it's not going to be as easy as this bed search piece that you just hit a button and say that everything stayed the same. So in terms of that complexity, we've increased our clinical team to be able to support that, but also to support all the associated social determinants of health. We currently have a behavioral health campus where both our outpatient, intensive outpatient services and our inpatient psychiatric hospital is based. And we also have the community food bank right on site there. And so it is a really nice collaboration, and we can address a lot of the social determinants of health right there on our campus.
Can I add one piece?
Please.
I went to an event a couple weeks ago, and I spoke to someone at Common Spirit who was talking about the importance of leaning into this workforce requirement and how crucial it is to get the public to lean into this as well, and for corporations and businesses to be creative in this space. And then how are we going to track that workforce requirement and volunteer hours? And so I challenge all of you to start thinking about that. I think that there's ways that we can be creative to support people who are now going to be required to have work, and how can we track that, and how can we support them through volunteer opportunities, through flexible work schedules, and all sorts of areas to just provide that access.
Julia?
Yeah. So I mentioned a few of the things that we're already doing as it relates to the Medicaid changes. And so maybe I think I'd like to add in a little bit to the social drivers of health and what we're doing and what we did with the SNAP cuts, because a lot of the times when we had conversations with our staff and our leaders, first off, there is so much compassion and a want to help people who are hungry, and so we really needed to understand what is the actual solution we need to solve for, because what we had people offering is let's do a food bank, or let's do a food drive rather at our center. Let's all just bring in food. But there's people who are really good at that, and that's our food banks. But the challenge with getting to food banks is transportation for a lot of our clients. And so that was the problem we realized we needed to solve. So our staff literally got in our vans, and they would take clients to the food bank. And then we also used some non-emergency, NEMT, non-emergency transfer medical transportation, and help clients get connected to that as well. And so I think there were a lot of things that we were thinking proactively about solving and really trying to solve the right problem, because again, so much compassion in this space. And then I would add also, because we've talked about the Medicaid changes, we've talked about the SNAP and just social drivers of health, but I think it's a good opportunity to circle back to stigma, and with some of these executive orders that are coming out, et cetera, and just a lot of the things that are happening, it can break down that trust with the healthcare system significantly. And so I was so excited by whomever asked that question, because it not only needs to be a systems responsibility, but it also needs to be you, me, all of us in this room together, having conversations with our family members, our friends, et cetera, so that we are breaking it down person by person. And, I think about like a drop in the water and how that one drop of water can then expand and affect so many things. So I would say you and me is, I think, the first place, as well as what Kelly had mentioned in some earlier in her talk as well, is embedding mental health services into the community, going to the community where they are. So faith-based services, having partnerships with churches, et cetera, having partnerships with sports teams. I think about like my nephew, who's involved in all of these sports, and who does he look to for support? Who does he look to for guidance? It's his coaches a lot of the time. And so what if our coaches were saying, hey, it's okay to talk about this. Hey, how are you really doing today? And then also knowing how to get them to care. So that's the access piece too, is how do people know about us if they do need us? What if we tell some coaches about us and have some conversations? So I think really thinking holistically about that whole person care and how all of these changes will affect the stability, not just the benefits, but the stability of our community.
Really good examples of the ways you all are navigating this. There was a commonality to being in community and the reducing of stigma. BHA and the desire to have these systems work better is because the systems haven't been working for people in our communities, but in particular for Black and Indigenous, other people with disabilities. And so the systems have to do better for those folks too, not just for the same people who've always benefited from the way our systems have worked. Could you all share how community is informing your work, or how divergent voices are helping shape the work that you do, thinking differently however you'd like to offer for that.
Can I
Julia's
start
already
with this one?
jumping in.
This is one of my favorite
But
subjects.
then we'll do Monica and then Dr. Wolfington.
Thank you. So this is truly one of my favorite, most passionate subjects. And I would say first off is we have a client advisory council of diverse membership. And the important thing about this council is not only do we, I would say, actually, let me say it this way. We have a bi-directional relationship with our client advisory council. We take questions to them about access, about programs, about services, et cetera, get their feedback, take it back to the board, to our leadership, to our staff, and then make changes. So we really partner together with our clients and having that active voice in how we deliver services. Also, we have a cultural development and wellness center, and this is one of the things I'm most proud of at Aurora Mental Health and Recovery, and offer a diverse amount of services through that division, one of which is healthcare navigation. So we have healthcare navigators that serve as cultural brokers as well as translators that come from the communities that we serve. And that's really important because, I think the idea around cultural humility is that we recognize that we don't have the answers, and so that we ask the questions. And so these health navigators not only navigate behavioral health, but all the other facets of health that that affect a person's overall well-being. So what does their social support look like? What does their spirituality look like? And then how does that inform their care? And I think another really practical way that they help us understand care is thinking about screening. How do we ask questions that are affirming to the people that we serve? Because if I ask a question in this way to this individual, it might land a little bit differently than if I ask it in a different way, knowing that we have to screen in a standard way, but how can we navigate that? So that has been huge for us. These health navigators speak 30 different languages. I don't know if you know, but Aurora's the most diverse city in the state of Colorado and the third most diverse city in the U.S. And so we really take that seriously. And I would say one last thing is representation. And thinking about that in the workforce, like what Casey had mentioned, how do we get to our youth and build that workforce pipeline so that it is representative of the communities by going to the communities and saying, hey, did you know that this is a career path you could take? Also with peers, I would say as well, peers are a great way to get that real life, real work representation. So this is a really important area to build trust with our communities, with having representation, with having those cultural brokers, and with amplifying the client voice.
Good examples.
I'm going to say y'all are crushing it over there. And my team better be taking notes because I think that's amazing that you have all of those opportunities. I think at Denver Health, we are have an incredibly diverse patient population and community and workforce that we support. And in behavioral health specifically, we have our community advisory panel for our mental health, and then we also have one for our substance use disorder community. And both of those community advisory committees are so impactful to guiding our clinical directions and being the voice, as part of where do we need to lean into. We have the Center for Addiction Medicine, which is an administrative body that supports our community. And so they're, as I said, Center for Addiction Medicine, they support our SUD programs, but we're expanding their scope because we know we need that for mental health as well. And we don't want to have these barriers and these silos either between substance and mental health. And I think someone else brought that up as well earlier. That's something in the last couple of years we've been working really, really hard on, is that one, if you have a substance use disorder, you probably have a mental health component to it. And honestly, behavioral health is integrated throughout our entire hospital. Our chair yesterday said that every single one of our providers is also a behavioral health provider in some way or fashion, from your surgeon to your PCP to your emergency doctor. So we try to integrate into all of these spaces and get the voices of all of our providers and our clinicians as well into how we're navigating care, because we rely on them to see our patients where they're at in those spaces. So we believe in no wrong door, and so that anyone seeking care we can help get them to the right place. And honestly, we went up to a place the other day and had the idea of, how about we have one door and then we're the ones who are navigating them. And so we're leaning into that peer model heavily as well. And the peers have a different influence than I've ever seen. And I'll tell you just a really brief story. So we had a peer, and you might see some of these on the news, for Caring for Denver, the tax initiative in Denver. They funded a grant that we run. It's called Thrive, and it's all about care navigation, and it enhanced our peer program, and it allowed us to bring peers in under a formal structure so that they could have support and so that they could support our patients intentionally. This program has integrated throughout our hospital, and we had a peer working with a patient who has had HIV their whole life and has never sought treatment and not wanted any support in this area. And the peer met with them and encouraged them to seek treatment, and the next day reached out to their PCP and said, I'm ready to get help. This is happening all over our hospital, and it wasn't a mental health or a substance thing. It was a different, a medical condition. And so being able to integrate like people who are like them into the community, into their medical spaces, to help guide them through the system, help get them, our peers are helping them get bus vouchers and walk over to get their IDs, because those are the things they need first before they can even seek care. So I think that's how we're integrating those voices right now.
Good examples. I love that. And the peer piece is so important. It's also one of the ways we've been encouraging providers to think more creatively. Peers have been around a long time, a rich tradition, very important. And there are some places in which they haven't used peers, or they don't see them as, or they're not high enough of a credential or things needed. And there's been a lot more value placed on it and a lot more impact, and it's been shown. And so we're encouraging folks to continue not just to use peers, but if you haven't already, to use them in your practice and in the care that you offer. Dr. Wolfington.
Yeah, absolutely. Well, first of all, I'm so impressed with the work of Aurora Mental Health and Recovery and Denver Health. And so I'm going to try to maybe touch on some things that are that we haven't already touched upon. But you leaned into this. I think that COVID allowed us to re-examine how we deliver care. And I think there's so many incredible lessons learned from that. When we were engaging in testing sites or vaccination, we were not sitting in a clinic and waiting for people to come through our doors. And so I come from the field of domestic violence. I was in it for a decade and a half before I made the transition over to Vail Health. And, in domestic violence, you met with individuals wherever they felt safe. That might be a Starbucks, that might be a Walmart where you guys are walking up and down the aisles. It might be their home. But with traditional medical care delivery, that was a very novel idea until COVID came to be. And so the fact is, in order to engage our community, we're continuing to lean into this model of doing it where the community is, where the community feels safe, and removing barriers wherever possible. So So we have case managers that meet with people at Starbucks, at Walmart, in parking lots, at school drop-off, all of those different components. And I think the fact is that when we lean into the community and meet them where they're at, we will have a better understanding of what they truly need because we're able to hear directly from the community. And I do want to emphasize this idea of navigators or peers or individuals that have a leadership role within the community helping shape that piece. And the patient advocacy committee is our version of our bidirectional committee. And there are so many important things that we gather from that as well.
We're gonna stay on this topic for just a little bit, but wanted to invite you all to feel free to ask questions, raise your hand, whatever, to feel like you can also engage in the conversation with us, and we'll have more formal time at the end. But if there's something like, ooh, I better ask about this, or this feels like an aha moment, please feel free to jump in, and I'll be sure to call on you. Yeah, go ahead. Look at you. I like that.
Well, it's what I do. So ultimately, how are you, I think the staff, because I'm a clinician, so the staff piece of it, how are you supporting your staff to maintain that staff and keep them, helping these challenging folks?
I can start with that. So again, I live in a community where recruitment is incredibly challenging, given not just the cost of living, but the availability of rental properties or even homes to purchase. But then recruitment, the work we do is incredibly hard, and the burnout rates are extremely high. And I think the fact is that for a while, especially in community behavioral health, there's this concept that it was a window of somebody's career, and then they would move into private practice, and that's where they would stay. So we were able to train people, provide this excellent experience, but the vast majority of their career window would be elsewhere. And what I have really felt passionately about is we have to find a way to be as lifestyle competitive with private practice. We have to be flexible with clinicians' schedules. We have to be flexible with our caseloads and our expectations. You can have one patient with exceptional trauma that feels mentally like 10 patients, and the clinicians in the room will understand this, but the fact is oftentimes when you're seeing a numbers report, it's still 1 hour of time. But in order for us to truly retain these individuals in a way that isn't just, I'm showing up at work because I have to, it's the people that are passionate and they want to serve and they want to be there, is we have to be incredibly creative. We have a number of wellness initiatives, student loan repayment programs, housing programs. We had 58 housing units available that weren't just single occupancy apartments. They're all the way from 4-bedroom townhomes to 1 bedroom, 1 bath in Eagle County. Those are incredibly important. But more so is how we fostered the culture, how we make people excited on Sunday night, or, with this inpatient facility, it's every day. Every day is a work day. But how people, the day before they show up at work, how we make them feel when they go to sleep at night. Are they dreading coming to work? Or are they excited to see their colleagues?
Really good. Monica? Or?
Yeah. So pre me starting at Denver Health, there was a program called Restore that was started, and it was a peer program for employees. So they have a Restore center in the hospital that can be accessed 24/7. There's coffee, there's chairs, and there's people. There's not staffed all the time, but you could call a peer any time of day or night. There's a call team available for any employee within Denver Health to call and speak to someone if they're experiencing something personal, or if they're experiencing something that maybe happened at work with maybe a colleague or a boss or a patient. It's all confidential. It's outside of the HR system. It's with this peer that works at Denver Health with you. and they keep it confidential, and that work is incredible. And they offer trainings, and they offer support for trauma-informed care. And I think that that resource is unique and very valuable to Denver Health. And I think, I don't quote me, maybe Mark or Amanda knows, there's thousands and thousands and thousands, maybe almost millions of people have touched Restore in some way in the last 5 years that it's been around. And it's a very valuable program. And I think that's the one way that we care for our people on the ground all the time.
It's interesting to go from housing support and the culture, and then it's coffee, a chair, someone to talk to. Just seems, and so just really good examples of the full range and the things you can do. Julia?
Yes, I co-sign all of that. And I genuinely appreciate this question. And one of the things that I'm also very passionate about is helping the helpers. And I think I can think of two other ways that we do that. And one is I try to do my best to think about why. So most of us went to school as clinicians and went into the field because we wanted to help people. And I think the first piece of that is always coming back to our purpose. And that's what rejuvenates me. And so having opportunities to celebrate their great work to each other, for each other, and then also in one of our meetings, we always start out with why do we serve? And so it's a great opportunity to hear some of these stories from our colleagues across the organization. And I feel like that rejuvenates all of us, connecting back to that purpose. And I would also say a challenge of helpers is that we want to do everything. We want to help everybody. And so one of the things that we talk about with self-care is boundaries. And so thinking about how, at the end of the day, can you not stay up at night? What can you do to leave work at work? Because we need you. We need your full brain. We need your full compassion and heart. And that begins first with you taking care of you. So having regular conversations, we do trauma-informed supervision. So really thinking about all the ways that this work affects our clinicians, and then also proactively working with them to think about, do you have a lunch break built into your day? If you are working with a client and something really tragic happens, what do you need? How can we support you? And so those are some of the ways that we're really trying to approach we're trying to approach a way to really support our clinicians holistically and for long term. And I think there's a technique in quality improvement called the 5 whys, and you start with one question and then you go deeper, deeper, and deeper. And that's one of the things that we've learned from our engagement survey is the why people are feeling burned out is because they're saying yes to too many things. We have so many changes happening all of the time. So that's part of my work, I feel like, as a leader. Protect them from the things that they don't need to do, that they don't need to know about. Try to, if we have all these changes coming out, really make sure that I'm expressing the why, and try and look for ways. I love standardization as a quality improvement person, but there's sometimes opportunities for me to step back and say, okay, maybe we don't need to standardize this. Maybe these are tools that we offer, as opposed to just coming out with oh, you need to do this screener now. Now you need to do this screener, and then you need to do this, and then you need to do this. So really looking for ways that I can think about change in a way that feels manageable over time, that helps our staff be able to do the work that they want to do every day and serve the communities they serve.
Really good examples. Thank you for the question, because it shows up in, again, all of the spectrum, from the housing supports and the incentives and the flexibility is a huge piece, and almost for any position, let alone in behavioral health, to the culture, to the human connection and the why. And it takes all of those things to be able to just retain, let alone the recruitment, which your group's been hiring a bunch of nurses and doing. How do we do that piece of it? So thank you for giving such clear answers and things that can help folks. We've talked about the staff in this case, the actual practitioners. Can the healthcare system be person-centered, and how does that actually look in practice? We're all looking to each. Monica, why don't you start us off?
Can it be person-centered? Yes, we can be person-centered. I think if we bring the person back to the center of what we're doing and why we're doing it, and take out or be able to navigate, if the regulations can be person-centered, if the payment can be patient-centered. So often in healthcare, unfortunately, payment drives care. And I think that's one of the biggest challenges. One, recruitment. We can't recruit psychiatrists because they can go and work in private practices or from home and make, a ton of cash without having to deal with insurance companies. And so we have to work extra hard to try to bring in psychiatrists to care for our patients at Denver Health because they have, easier options out there. But that's because healthcare has turned up into, not turned, it's been for a very long time around financial means. And if we could focus on the person and how we can support them holistically and provide a value-based care system, that's the path forward that I believe. We are pursuing a comprehensive safety net. We're almost there. We're so excited. There are some regulatory things that we're navigating. And hoops and barriers, and there's a lot of challenges to get to be able to provide care is so hard sometimes. It's like, we just want to take care of people, but we have to do all of these other, the 300-page book of regulations and learn and understand that just to provide the care. Excited to navigate into this comprehensive safety net model where we will be able to provide care to our patients and they'll be able to access all the levels of service, and Denver Health will be able to expand our services into areas and to do things that are uncompensated right now. And I think that's going to be really important. And then it's also going to hold us accountable. It's going to hold us accountable to that. Are we doing this efficiently? Are we doing this effectively? Are we actually moving the needle in the quality of care that they're getting and in the outcomes? So often we're so paranoid, and our data is driven on access and not driven actually on the outcomes of our care. And so being able to hopefully focus our mind a little bit more on that instead of just, these are access numbers, and we talked a lot about access, but what are we talking about? Where we move people on the mental health spectrum and able to support them and help them through recovery instead of just looking at harm reduction, but actually looking at that the care that we were provided actually made changes to their lives and being able to provide those outcomes instead of just saying, we gave access to all these people, but we don't know if it actually helped.
Agreed, and I'm going to piggyback, if it's okay, about the outcomes. So I think this is one of the exciting things that's happening in behavioral health care. In physical health care and medical health care, let's say, for example, with diabetes, we're able to track somebody's symptoms and improvement with diabetes. And that's been a little bit harder to do with behavioral health. And so what we're doing now is really expanding measurement-based care. So that's using validated screeners like the PHQ-9, which measures for depression, the GAD-7 that looks at anxiety, and the CSSRS or Columbia that looks at suicidality. And so we're looking at and tracking individuals' symptomology over time with the client. And so this can be really helpful. You know, you think about when you go into your doctor's office and you have these ongoing conversations about whatever your medical need is. And he or she says, you know, last time you were in here, this was where you were at. What do you think is changing? What do you think we need to do? And we can now do that with behavioral health care. And so what that does is it puts the client in the driver's seat of their own treatment. And we also talk about like joint treatment planning. So making treatment plans not for the patient, but with the patient. And so when they're really able to see and understand the insights into their own symptoms and their own wellness and really be able to understand, oh, well, I was doing really well at this time, and this is what was happening, and I was taking maybe this medication, or we were talking about this thing. So maybe we should do more of that. And so the clinician's able to support and drive that as well. And it's helpful for us not only at the client level, but then also at that population health level. So we can start to really look at outcomes, look at evidence-based practices, and think about what can we plug in here. And that's where I'm kind of moving away a little bit from standardization and thinking about, let's put the tools in the hands of the clinicians. Let's make sure they have the training that they need, and then they can work with the client to pick from their toolkit and help the client achieve their own goals for their wellness.
Yeah, and I would completely agree with all of those pieces. And I think something that has been really nice with this administration of the BHA is that they're open to discussion about the challenges that are associated with person-centered care. And one of the ways that funding is broken down is it's broken down into these traditional program areas, and they have been decided and in these buckets for a very long time, and I believe they come from the federal government, and you don't have a lot of sway there. But they don't always work for every community. Programs that were designed, you know, a decade, 2 decades ago in an urban setting may look very different in Eagle County, Colorado. And I will say, you know, I think it was a month ago, I sat down with your team and Commissioner Smith and talked about the pieces that were working really well from some of these traditional programs, and then some of the challenges, some of the things that actually are true of our workforce or our patient population. And we were able to have a pretty dynamic conversation of talking about what ways can we enhance this, both for patients, but for providers, because it goes back to your question, is if the providers don't understand the why, or if they feel like the why is so disconnected for 7 pages of forms they have to complete, because this has always been the forms that have to be completed, that can lead to burnout. And what I think is just really unique is the BHA's willingness to lean in and say, we understand that we need to change some of these things too.
You're free to elaborate. Just because I'm sitting here, you can still give
Everyone knows
you're
I'm talking
dying.
about
Somebody
C-cars. Everyone knows.
Some of the questions. But we have to be able to think creatively, especially for folks on the ground. And we're trying to be true partners in the work, because we can't fulfill what we want for Colorado, that mission vision piece, if these folks don't have what they need or the staffing of the things. Some of you, all of you, have mentioned different ways in which data is informing the work, from screening tools, from community councils, from these access points that you have to collect for payment. Data, being data-driven is often cited as a best practice. How is data informing your work today? What are some examples of that?
I would say the most important data to me really lends itself around access, affordability, and then what I call the white space. Because what we have is data on the people we see. But I also really need to think about the people we're missing. Who are the individuals that are not accessing our care? I care very much about the kiddos in our schools that are accessing our school-based health services, but who are not? And are they accessing our multi-specialty physician clinics? Or who is actually slipping through the cracks and not seeing a provider at all. Same with our seasonal workers. Do they have an established PCP? Are they engaging in preventative health? Or are they showing up in our urgent care setting only when a bone is sticking out of their body? So to me, it's so important to look at the data we collect, but also look at that as being transparent against our community and see what the white space is and what we're missing.
And we're a learning health system at Denver Health, and we've engaged in that as a system. And then in behavioral health, we're developing our own team. And a learning health system is one that goes through a cycle. Like I said, it's a system. So it's the data, you collect the data, and then use the data to inform the questions and to see what you want to change, and then you make the change, and then you take that data back and you keep it through this cycle. And we use that for patient care. We use that for workflows with our team members also, to understand what's working right. How are we, what's the best way to move a patient from one area to the next? Are we transitioning patients appropriately? Are they showing up in the outpatient clinics? Are they getting from the emergency departments to the inpatient areas appropriately? What are we doing with that? And then how is that informing the change and learning, and we're learning from that to improve constantly. So it's just a cycle, nonstop, where we don't just get data in and be like, oh, that's cool, we're doing it. We got to use it to inform all of our decisions.
There is nothing that kills my soul more than collecting data that goes nowhere.
Yes.
Agreed.
Right? And so that is a big part of my passion and what I try to do. So for CCBHC, we have quality measures. And these are some standards from the federal government, and it has been a huge lift to stand these up at our organization. So these quality measures look at access. They look at depression screening and follow-up. They look at remission, and then also social drivers of health. And so one of the things, to your point, that I had to do is I had to go to our clinical teams and say, can you do 5 more things in your intake? Intakes are already so long because you have so many things you need to do. So I had to work really hard to not only share the why, but also this is what we're going to do with it. And so one example is with the social drivers of health is we are looking and using a standardized tool, the health-related social needs tool, and we're using that to determine, does somebody need short-term case management to just help with a few tasks, or do they need that systemic care coordination and kind of more long-term holistic approach? And so that's what we're testing right now. We're piloting that, and then we'll expand that. It will also help us understand, do we need more case managers? And my hope is that we can tie our HRSN and our additional screening for social drivers of health to outcomes. Because you know what I think we know and we can assume is social drivers of health do have effects on our behavioral health symptoms. And can we correlate those together and then understand the impacts of adding more staff like case managers, care coordinators, et cetera. Because we also have a responsibility to our payers, all those federal dollars to demonstrate these are the people we're serving, and this is the outcome and the impact of that. And so I'm trying to help us use data that we already have to collect in a way that informs not only practice, but then hopefully makes everybody's jobs a little bit easier. Because if we have a case manager helping with this stuff over here, not only will that benefit the client, but then the clinician can focus on some other things, and we can have this whole treatment team really serving that client together. I would also say it helps us with strategic decisions. So there was an article that came out, I believe this week, from Open Minds, and it was called A Moment for Strategic Hibernation. And they talked about this idea of protect, probe, and pivot in these very uncertain times. So you protect the services that are high value value, that are having a lot of impact, that are really mission critical. You probe in areas where you might think about expansion. So thinking about what questions do we need answers to expand, to possibly rethink some of our service lines. And then you test that on a small level, and then you make some pivot decisions so that we're using data to truly drive these decisions in a financially responsible way and in a way that most impacts the communities we serve.
Go ahead.
I was going to add one more thing. If a data need is consistent data. Consistent data and consistent terms, and if we could have a data dictionary that matches each other and that we're asking the same thing, and when we say patient name, it means the exact same thing, and it looks the same, and then we can
First
share
contact
data. ROIs, a shared ROI across the board. Those things would help us to collaborate better, to work across our systems, to utilize resources better, because a lot of that gets held up in just not being able to share information.
I'm going to invite questions in just a minute, so you can be thinking about that. I wanted to follow up, though, and Dr. Casey, you had said about the white space, the people that are being met. How do you know if you've missed something? How do you know that if it's a blind spot, beyond just being aware there are blind spots?
Yeah, I think it's incredibly difficult. It's a lot of community engagement. It's looking at the individuals that are serving community in a different way than us. We have a tremendous amount of partnership with our community. We actually fund over 15 organizations and give over $2 million out to our community nonprofits because we know there is no wrong door and it's not always our door. So it's looking at Bright Future Foundation that does domestic violence, sexual assault, or My Future Pathways, and who does first generation youth in Colorado, and trying to identify, okay, if these individuals are doing the same screenings that we're doing, so consistent screenings, and they're identifying this need, and they're making the referral, and then this person is not coming through our doors, where did the gap happen, and how do we reduce that gap? And that might be changing our programs. It might be warm handoffs where we're doing more work in engaging in the community with these particular pieces, or it might actually be training and providing partnership, because sometimes when you have a trusted organization, no matter how many warm handoffs or cards and referrals and how easy you make it, you're my trusted person. So I'm only going to Monica, and it's very difficult to change that. So instead, how can we train Monica to do some of the navigation work that we were going to do ourselves too?
That's great. And Julie mentioned a good example around taking the data and saying, does this help us understand if we need more social workers or if we need something in particular? Monica, is there something from that learning cycle that you shared where Denver Health was like, oh, okay, this is what we'll do?
That's what we're working on. I would say that we're not there yet, but that's what my dream is. That's, is to understand all of those intricate pieces of, we're at capacity. We have a 500-person wait list. What does that mean to have a 500-person wait list? Does that mean they all want to come to us, or were they just all referred to us? Does that mean they all want care? And then what's the capacity of the social worker or the psychologist or the psychiatrist, and what can they take? And what does adding one new FTE do? Now, if we don't have space, then that's the other thing that we're trying to navigate is how much space does one new provider require? So construction friends, this is the work that we're navigating. If we want to add more patients, how many more rooms do we need? How can we be flexible with our spaces? I think that was one thing I heard when I did a tour the other day is so important, is that if you're creating spaces that you understand how to flex them back and forth depending upon your demand. So I would say, yes, we need to learn all of this, and this is what we're trying to do right now. So we'll come back to you.
Good. A teaser is that of the BASO model that I showed you in lifts, the broader question for us when I showed you the care continuum, how do we know the system's getting better? So if BHA is charged with it, how do we know it's getting better? And so we have our the performance reports, the BOSSOs were just launched in July. Their quarterly performance reports will be coming. They're due now. We're reviewing them and assessing. They'll be made public. We also do network adequacy assessments with them in each region. What's missing or not? What do we need for the network to be adequate? But the performance part of how do we know it's getting better? So you all will have a chance to read those. It's good reading, I think it is, to read through those and go, are we answering that in the best way? We have 6 performance measures right now for them, for that model to see if it's working. But we'll be getting feedback, input on that too, to say, are we getting the right data to assess it in the right way, to know it's actually working? Because if it's not, we need to adjust. And so just a teaser that it's coming out soon for good reading over the holidays. I'm going to open the floor for some questions before I come back with a couple more for our team. We're in the final 20 minutes, and so it's a good chance to comment or ask questions about something on your mind. Yes?
I would like to switch a little bit and learn a little bit more about exposure to nature. And I know Laura's got a large landscape area that will help staff maybe relax. I don't know if you use it for your patients, 60 to 55 have nothing. How do you think about nature and how you use it? And I know on paper it makes a difference in staff retention and stuff, but is that reality?
What a great question. So we are so excited. We just built a new building, our Potomac location, and that was built in very thoughtfully into that building, in creating spaces where clients and staff both can have access to fresh air, sunshine, nature, et cetera. I think that's a key part of a trauma-informed approach in building and just housing and having treatment and all of those kind of things. So I think it's a part of it. I would also say this is a little bit of a pivot. So not necessarily Aurora Mental Health and Recovery, but when I was a clinician at the Colorado Mental Health Hospital at Fort Logan, that served an inpatient hospital serving individuals with severe and persistent mental illness, we had recreation therapists. And these are magical, amazing people that talk about whole person care, that would take clients outside and do all kinds of activities, from crafts to gardening. Oh, we had the coolest project where we took this kind of old, just rocky area and turned it into a garden and grew pumpkins and all kinds of stuff there. And getting our hands in the dirt, man, that's therapeutic. Feeling like a human, that really helps us feel like a human when we're doing just those everyday activities, connecting with nature. They would go fishing, et cetera. So I would say it's not just in access around our buildings. I think that's hugely important, but it's also in just thinking creatively about how do we help our clients develop leisure and recreational skills that help with depression and anxiety long term.
And I would completely agree. I think it's so incredibly important. And we recently opened our inpatient hospital, and so I spent 2.5 years prior to that in the development process with Hazelton and the construction piece. And that was one of our non-negotiables, is an inpatient facility that only has internal space isn't really taking advantage of all of the healing properties. And so both our adolescent unit and our adult unit have very substantial open spaces that overlook our mountains, our New York mountain range, because it's based in Edwards, Colorado. It's incredible. And the fact is there was a lot of challenges because you guys, we get snow there. We don't have it right now, but apparently it's going to come again. It comes every year. Our mountain opens tomorrow, so I don't know if it's going to come by then, but it's eventually going to come. So snow, ice, the weather conditions could pose a number of challenges. And then we were really thoughtful of the privacy of the patients. And so a lot of very thoughtful and mindful and trauma-informed construction pieces went into effect, including ways that there's paneling where you can look out and see the New York mountain range. Like you're on the most beautiful deck in Edwards possible, because it really is such an expansive deck, but that there's grading so it doesn't allow individuals who have homes in the facility to come in, see the identity of the patients in any way, as well as snow melt on the flooring. And another thing we do a lot with is tending to plants, both in our outpatient space and our inpatient space, how we're really engaging with plant-based horticulture therapy, where we're talking to others about what's important for this to thrive, and what's the parallels that you need in your own life to thrive. And if you're not thriving here, what if we move this plant just a little bit over here and we make this shift? So what is the small shift that now they're in the sunlight and they're thriving, and what you could do? But then also, just so you know, I have a cactus in my office because that's all I'm trusted with, so.
At Denver Health, you guys have seen our buildings. They're incredibly old, and we're very challenged by being able to have a lot of outdoor space, especially for our patients. In our adult inpatient area, we don't have any outdoor space. We have lots of beautiful windows, fortunately. But our adolescent area, we have a really amazing outdoor space up there. We have a 21-bed unit that services behavioral health adolescents ages 12 to 17. And they have a little courtyard. They have a basketball hoop out there. I was actually out there yesterday giving a tour of the space, and the ground is soft, and they can feel the breeze, which I think is important. They can see the mountains. They can write on the walls. Our occupational therapists bring them out there to do gardening, to do exercise, to just do breathing exercises. And they have a lot of access to this area, which is really, really important. And we want to recreate that as we grow and develop and find new spaces for our behavioral health patients. It's really been like top of mind as we're thinking through like what does the next phase for behavioral health at Denver Health look like in a new building? How do we incorporate some more outdoor spaces or nature into their environment, as we are, city bound, but we can be creative. And we went up to Vail and saw your beautiful space and was very inspired. Also went to Summit Stone. There's a lot of places that do incorporate the outdoors into their environments. So I'm really encouraged by that. And hopefully with new buildings, we'll be able to keep moving that forward.
Great question. Thank you about the connection to nature. Other questions from the group, please?
So do you have things like art therapy and wellness programs, physical gyms, those kinds of things too?
Yeah, I think something that's so important to us is being able to embrace novel treatments to behavioral health. If we think about traditional talk therapy or even medication management, it has been around for a very long time, and there's been tons of innovation in that space, which is incredible, but it does not work for everyone. So our Vail Health Behavioral Health Innovation Center really takes this and focuses on innovative treatments. You heard a bit about our work in the psilocybin space, so we're working on psychedelics as a novel treatment to treatment-resistant depression. We are also looking at hot sauna and cold plunge and the combination of both. And the thing that's really nice when we think about some of these pieces is that these are low barrier. The fact is that a lot of people, especially where we live in Eagle County, if we're really identifying that cold plunge can be healthy for individuals, we have the Eagle River, we have other things. I know that people buy these traditional cold plunges, but there's a lot of ways to access this care that is no barrier to treatment. And that's what we're trying to really think about, or what is sustainable. And so looking at those novel approaches. And then more complex. We have transcranial magnetic stimulation. We're in the process of looking on launching ketamine therapy. But the fact is that we want people to have access for what works for them, and knowing that the traditional methods don't work for everyone.
I know that we lean into all of that, especially our adolescent unit, our adult units, and then I want to highlight that we also run Denver Cares, which has a residential treatment program there, and we built them a gym So the clients and patients can go up to the gym and utilize the gym right there as they're out looking for work or they're there every day trying to work on themselves. They can still get that physical activity.
And so I love this question for a lot of reasons, one of which my training, I have a master's in neurologic music therapy. And so that's what I did at Fort Logan, and talk about therapy that, like, it was so powerful because there's a lot of individuals that I got to work with that their illness with schizophrenia was so complex and so severe, and we were trying everything we could think of, and at pharmaceutical, we were thinking, like, they did ECT, et cetera. And so sometimes I'd get called in for some of these really hard cases, and it was the best part of my job, because the way that music is processed in the brain can be used in a very applicable way by a certified music therapist to access these different things. So, for example, it's very effective, and I found it very effective with individuals who were responding, what we say, to their own internal stimuli, having a difficulty completing their ADLs, their activities of daily living, that would really not be able to converse with you, even make eye contact with you. And I could use an instrument first off just to start that first step of communication, which is eye contact, and then start to mimic things in conversation. And like, verbal communication is such a complicated cognitive process. And so if we could simplify that through music, through instrument playing, it could be so powerful. And I had so many circumstances where I would see just in one session such a transformation. And so I think it's so interesting to think about, like rec therapists, music therapists, art therapists, TMS, all of these different ways that we can holistically, and that's person-centered, right? Like, really thinking it's not a one-stop shop for everybody with their symptoms. So appreciate that question.
Now it makes me want to do more musical something. Yes, it was very intriguing of how you described that. Other questions or comments from the group? Yes.
You talked a lot about ways that this community can kind of engage with you and support you, but I was just kind of wondering, there's I wrote a lot of lists, right? If you could drill it down to one thing that would really make a difference, even if it's in a small way, that we can kind of take away for this community, for the AAC community, that would be helpful.
The question was about a takeaway for the community from the group.
I think that what we haven't necessarily talked about, but Kelly, you talked about this in your discussion, is how important stigma reduction is. And I think oftentimes we think about really big campaigns that reduce stigma. So these are the things that are plastered on the side of the bus, telling people how to access care, trainings that focus on signs of suicide and how to engage in these conversations. But the fact is that the thing that makes a difference is being the person that you see and you ask someone how they're doing, and you know they answer in a way that means that they're not doing that great, and that you lean in and that you have the conversation. And even if you don't have the right resource, that you let them know that you're going to help them find that right resource. So I think for the community, the best thing that anyone can do with behavioral health is making it a priority in your everyday and engaging with your friends and family.
Yes, to all of that, and learning about what the resources there are out there so that you can help support get them to the right places. Learning about opportunities and that you can support and be involved in. We can't do this on our own either. So there's volunteer spaces, being engaged in that, and listening to your families and your friends and being a partner there with your employees and really encouraging it there. I would also say when in thinking of design and spaces, of let's be really trauma informed, and let's listen to what the best flow will be for the patients, and being creative in that area. I think that's something that I'm really leaning into as we at Denver Health are, considering building a new behavioral health building. And we just walked through a building last week, and they're like, this building's great, but it's got this big gap and hole here where it's big and gorgeous, but we can't walk patients through here because it's not a private space. There's big windows and the public can be in here, so it wasn't very thoughtful. But it needed to be grand and gorgeous, and so really being intentional and thinking through all of that when designing and leaning into that and supporting us in building our new buildings or redesigning our spaces so that we can be more trauma-informed for our patients.
Agreed. And I would say, and I'm sure you all do this, but including the people that are going to be doing the work in the planning of the building, et cetera. I was talking to some folks in the back at the break, and I had said when we did a remodel at Fort Logan, and when we came back into the building, the main milieu area, the main gathering area had one outlet. And that just doesn't work for a lot of different reasons. And so that we had to do some emergency kind of stuff before we moved any patients in. And so I'm sure you all do that. So I would say that's like one key takeaway. And I just want to circle back to how important what Casey was saying around how it takes each of us sitting here in this room as a human being, supporting our fellow human beings and just being that like safe space for each other. So if you've heard of, maybe you might have heard of adverse childhood experiences. So it's a way to talk about trauma with youth. And one of the things that I remember taking away from this training many, many, many years ago is that one of the most impactful things for youth to have, if they've had an ACE or many, is just a safe person in their life. And it can be anyone. It doesn't have to be a parent. It can be, the coach, the aunt, the teacher. And I think many of us sitting in this room can even think about who was impactful to us in our youth, who helped shape us in our youth. And we get the opportunity to do that, not just for our youth, but for each other. So I think that's probably my big takeaway.
In our final few minutes, I thought we could open for you all. This is the last year of the current state administration. What's a hope or goal that you might have for the behavioral health system during this final year?
Maybe I'll take a turn starting us off this time. I think for us, it's systems that work together, that have integrated data so that we're not just sending data off into the ether, that we can both use it together to really understand how we're serving the communities that we're serving. And then also just some stabilization would be great. With so many changes, we understand, I'm like always bringing change to the table at my organization, so I know how hard that is. But I really think like stabilization and standardization so that we have similar definitions in data, et cetera, and so that like if there's regulations that, well, it says this over here, and this terms it a little bit differently over here, how do we do that? So standardization across regulations, stabilization of change, so that we can reduce some of that administrative burden and really continue to serve the clients that we love to serve every day.
I love that. That's beautiful. I'm going to go with transparency, and I think it actually goes to the data piece too, is that to really understand the services that are being delivered across our state, how could the BHA help us paint that picture and what's available, who's providing it, how people access care, and also what is funding it? What are the funding mechanisms that are going dollar to dollar to each community, and how can we make a more sustainable model? Because I think that we're going to continue to see cuts, and I think the fact is that we're going to have to really lean into the fiscal responsibility of our programs. So if we could really understand how all of the programs are being funded, what programs are being funded, and what are the most effective, I think that's really important. And I think some of the data that we're capturing, again, I think Monica, you said this, that it captures utilization, but not patient experience. And to me, how someone feels after they've used my services is the most important piece.
So all of that, especially all of it. And, I heard this the other day and it really resonated with me is don't take away our progress. I feel like we've made so much progress in behavioral health over the last few years, and I don't want it to dwindle to the background because there's not enough funding for it, or we just, it became too hard. So let's keep pushing forward and keep moving forward with behavioral health and make sure it doesn't, not become the shiny thing anymore, but it stays in front and center of everything that we do. And then just a continued investment in the collaboration, because I think that is crucial. We appreciate the open doors that we feel from the BHA, being able to call anyone up and have conversations and talk through challenging situations and be challenged on both sides, and knowing that not one shoe fits all, and that we're a different beast at Denver Health. We know that Vail's a different beast, Aurora's different. Every single facility is different, and so we have to make adaptations. And so we appreciate the BHA's willingness to come and listen and to work with us and alongside us in supporting our community.
Can I close this out with just a 3-sentence client's story? And this, when we talk about not wanting behavioral health to not be the shiny thing that goes away, how important this work is. So this client, they shared, and this is obviously permissioned and all that, they said, "It's crazy to think that I was homeless on the street, sleeping on the sidewalk, dealing with my symptoms, asking God to just take me away. One day I decided to go to my father's and ask for help. If it wasn't for AMHR staff member, I would never have gotten the apartment that I am typing this message in. I thank God every day, as well as those who helped me get to where I am today. The organization has helped me get 4 jobs in the time I've been with them, and I very much appreciate the help." And they went on to say that, and I think you heard the suicidality in there, and that this really saved their life. And so that's what's at stake here, and that's what we're proud to do. That's what you all help us do. So thank you for all that you do in supporting us as well.
Can you join me giving a round of applause for our panel today? Fantastic. Colorado's lucky to have this group of providers and the many others around the state. I get the impression I'm handing this off to you then.
No, I'm just getting ready for my part. Any last?
I think I have said enough. Thank you. Thank you all.
Usually the applause means we're done, but no. No, I just wanted to say a couple closing comments and let you all get on with your day. First of all, thank you to the panelists and Kelly for teeing up the keynote and facilitating. So another round of applause. Thank you, guys. Yeah. So it was, very important topic today and a good discussion. Some great ideas were shared. And I appreciate the knowledge sharing and encourage us all to continue the conversation outside of this room, in our AEC industry, but also in our communities. Thank you all for being here today and dedicating your time. Hopefully you found value in it, and we will see you next year at our annual event. Thank you to the Turner and Trainer team for organizing this. Steve, Kat, Trevor, Anthony, and most of all, B, thank you. Very successful event again. Thank you, Toby, for hosting this really cool space. So hopefully we see you at the same place, same time next year. Thanks again.